A new dawn, a new horizon of healthcare delivery and patient safety. We have a goal, a noble drive.
Hand in hand, step by step, we will thrive.
To march ahead together for a bright and shiny future with patient safety and quality healthcare. We are CAHO, your healthcare companion, standing right by your side. Joining hands for building a vision, shaping a culture for patient safety.
Setting up standards with best foot forward. Won't ever leave no stone unturned.
We wear our pride on our sleeves, work with passion like a breeze, train people, enhancing their skills, spreading the message of quality healthcare for safer patient care, a better nation.
We have a goal,
We have a goal,
a noble drive.
noble drive. Hand in hand, step by step, we will thrive. To march ahead together for a bright and shiny future with patient safety and quality healthcare. We are CAHO, your healthcare companion, standing right by your side.
Good evening to all of you, all the participants, dignitaries, and the speakers. I'm Nishant Jaiswal, Secretary Healthcare Division, CAHO. I welcome all of you for the 20th Healthcare CXOs Roundtable. And today's topic is Dimensions of Digital Health in Hospitals and Need for Training and Contours of Curriculum. I welcome Dr. Vijay Agarwal, President CAHO, as a moderator to take forward this CXO roundtable. Thank you, sir.
So, good morning, good afternoon, and good evening, depending upon whether you are Elliot Sloane, who is joining us at 6 a.m. in the morning, or Manish Kohli, who is normally in US, but today in Thailand, so joining us later in the evening, and all our fellows from India who are here. So we are here for a very exciting topic, and as well as to bring in now this group of people who are close friends of CAHO, I can call them, led by Dr. Manish Kohli, who is a seasoned physician executive, I will say, and a CEO of Beyond Horizon Health, specializing in innovative healthcare solutions and digital health strategies. A respected speaker and advisor, he has pioneered transformative care models worldwide, focusing on reducing inequities and improving outcomes. As a founder of Full Alliance for Digital Health and Equity, Dr. Kohli works towards creating resilient communities through equitable healthcare access. And we are at CAHO very, very proud, and we are very eagerly looking at an alliance also with Full Alliance, a collaboration with Full Alliance, to take this whole concept of the digital health forward. Ladies and gentlemen, we are living today in an era where we really are losing the boundaries between the physical and the digital. And the thing is that I would say that amongst us, there are a lot of people who are today very well aware uh, of the advancement in digital technologies and digital health, while there are others who have not taken, let's say, the efforts to understand, and for them, the whole thing may look a little more bleak. But a time has come when all of us have to understand this medium so as to deliver a better healthcare. And already, I think just a few days back, we had an excellent session on the digital health standards of the NABH, and which has also shown the path to people as to what the digital applications and how those standards can be applied. However, now just to take that same discussion forward and to understand that what each of us have to understand, because the thing is whether when we start using WhatsApp for healthcare, that is a part of digital health. When you start using some EMR solution, that becomes a part of digital health. So anyway, I will now be asking, of course, can we get on to the next slide for, and of course, he will be joined by Elliot Sloane, who is the president Foundation for Living Wellness and Health Technology Faculty and Advisor, WHO. Elliot had in the past, when I talked to him last time, had worked with ECRI, which is also a very reputed organization, and with whom we can also collaborate. So over to you, Manish, to start the ball rolling.
Thank you, Dr. Vijay, and good evening, everyone. Good morning, Elliot. Truly an honor and a joy for both Elliot and I to share our thoughts today, and really, I think, to have an open dialogue about enabling digital transformation at the front lines. As Dr. Vijay and we were preparing for this session, one of the things he said has been so deeply resonant with me. Is that we don't need more certification, we really need more skills at the front lines. And the theme was, the background was that a lot of countries have made strides in adopting technology, but when we look at outcomes, quality and safety, literature has supported that we've really not made a dent. And really, I think for us to come together to really be focused on what's the problem we're trying to solve, and begin to look at how we align people, processes, technology, and data to make it happen. So it's really a multidisciplinary effort where we really want to hopefully create some thought-provoking questions that lead to future conversations as we all sort of work towards enabling transformation in the front lines. Thank you, everyone. We're really delighted to begin this journey and embrace a shared passion towards transformation in India. Tom Judd is our third partner collaborator who regrettably could not join us today. But he's definitely very committed to helping us achieve what we set out to. So the agenda for today is talking about the CAHO Pull Alliance partnership that Dr. Vijay alluded to. Really talk about dimensions and impacts of applied digital health. And I think the key is applied, and it's not really about a set of competencies that we develop. It's really building capabilities. What do the new workforce look like to support a digital enterprise? We can put all the technology we can in a hospital, but if we don't have the people supporting it, the life cycle is very short. And then have a conversation around what are the drivers of change, and then what do we do from here? So a little bit about Pull Alliance for Digital Health and Equity. This is something that has become a labor of love, not only for me, but for Elliot and several other collaborators. And essentially what we've observed is that there are a number of organizations doing great work globally, delivering care to individuals. However, they lack the depth and the expertise to really embrace digital transformation in a manner that is going to transform healthcare. So our vision is to really bring together a community that creates empowered and resilient communities through digital bridges, and focus it on building equitable pathways for access to quality healthcare. And the focus here is on quality. It was a very thoughtful gesture that is not about access to healthcare. Every human being deserves access to a basic level of quality healthcare, educational opportunities, and better livelihoods. And they're all intertwined, because better healthcare leads to better education opportunities, better education opportunity lead to better livelihood, and the cycle propagates itself. So our mission is to strengthen frontline partner organizations globally like CAHO that are serving to bridge disparities and inequities amongst the vulnerable. And we would say that in many of the economies, and I like to cite the example of my mother who did not get the standard of care in India, that inequities exist even people who have access to healthcare. So for us, the mantra around quality is important. And we believe in elevating communities through sustainable access to better health, better care, better education, and better livelihoods. In short, what we really hope to do is help bring health and care into healthcare. We work with an ecosystem. So it's really not Elliot and Manish and Dr. Vijay. It's really a number of collaborators. And what we have learned is that, there are excellent assets, excellent work being done at institution level, but it's siloed. And one other thing the Polar Alliance hopes to do is break down those silos. So there is a lot of cross-pollination, cross-sharing of best practices, educational opportunities, and really solving problems together. The framework we embrace is really focusing not just on technology. And I think this is a key differentiation. When most people talk about digital health, it is largely around technology or an app. And I think what we really need to understand, this is a four-dimensional subject, where digital health involves not just technology and innovation, but strategy and governance, change management, implementation and operations, continuous improvement. And then talking about what are the programs that are being solved. So really, it's the clinical programs that need to, clinical and operational programs that need to lead, any kind of digital transformation. So what are the quality measures that we're trying to improve? Is it cardiac care? Is it orthopedic care? Is it diabetes care that we're trying to improve? And how do we begin to bring the different components together? Quality and safety as a program, even data and technology management as a program, supply chain, leadership, and the list goes on. This is representative. But the central theme is workforce. Ultimately, it's really about teaching people how to fish. You want to create leaders and frontline individuals who can critically think, who can ask the right question, who can participate in a digital enterprise. Digitization is not about bringing an app into an enterprise or a medical device. It is much broader than that. It is really ensuring that whatever investment in technology that is made for an enterprise is aligned to an outcome. Because if it is not, it's a cost. And we can say, Elliot and I can cite many examples around the world where technology has become a cost rather than being an investment. I'll pause there. Elliot, you might want to add a sentence or two here.
I was just typing. Yes, and in addition, our patients are part of our workforce now, because they now play an active role with the apps and the web services and using devices in home settings. So our workforce education is a very broad opportunity for all players, and also just in the digital data and technology management and programs. We have so many devices that now are either automatically or periodically providing data into our systems. So it's an everyone play situation in digital health. So there are tremendous opportunities for us to take advantage of the data landscape that is growing quickly.
I think, Manish, you have very beautifully explained this particular concept, because this is what aligns to that each particular part of the healthcare delivery, for example, supply chain is different as compared to the clinical processes, or let's say the admission or anything else. And each of these areas will have their own problem statement and their own digital application, which that person there has to understand in depth as to how digitization can help my part of the workflow, rather than trying to understand each other's or the whole elephant. Because today, let's try to feel that each part has to understand that what is it that we can solve and how can we make the healthcare either more affordable or more efficient, or somehow it has to make an impact. It should not be merely for the sake of using digital technology.
Thank you. Well said, Dr. Agarwal. And this is the current state, regardless of the country you're in. Whether you are a 7-year-old child who draws this picture after a doctor's visit, and there's something wrong in that picture, or whether you're in India, where you have a doctor who is surrounded by hundreds of patients, there is a problem. We are burning out the workforce. We are not optimizing their skill set, and we're not serving our patients in the best manner possible. So there's an opportunity here in both scenarios. By the way, what's wrong in the picture on the left is that the doctor is smiling. Typically, most doctors really don't like typing into the computer. And this is one of the things we want to avoid in India, where you don't create a paradigm where digitization leads to creating glorified typists rather than really an empowered workforce. And I think this is really, really important as we begin to invest in India, and I think the macro drivers, which we'll touch on, are beginning to emerge. And I think India has a unique opportunity to create a model for the rest of the world, where low-cost digital transformation is created successfully, and it can be exported, either as a product, a service, or even as a case study. And this is startling. There's 30% waste in healthcare. Globally, when you look at every dollar, every rupee that's spent, 30% does not really align itself to better patient outcomes. And when we think about the amount of money we're spending as a percent of GDP is 10% of every rupee we earn globally is being spent on healthcare. That's a lot of money. And the disparity there is that countries like India are spending far less than the developed countries. In fact, 50% of the global spend is in developed countries, rest in the developing countries. So the sheer number is large. There's inequities in how the money is being spent, and there's 30% waste there. So if one was to ask, is there magically going to be more money in healthcare? I would say if you're thinking like a business, you could never run a business with 30% waste. And I think it'll be implicit upon us to begin to think about how we squeeze out inefficiencies. And this is really part of the goals of digital transformation. How do we create an enterprise that is much more nimble, much more efficient, and is able to deliver higher value to its customers? Healthcare is a local subject, but the challenges remain the same globally, where regardless of the country, safety and quality are a concern. I mean, there are 5.2 million deaths annually in India due to medical errors. This is according to a WHO report. 1 in 10 admissions leads to an adverse event. 1 in 300 admissions leads to a death. I mean, I'm preaching to the choir here. This is an organization, CAHO, that is trying to solve for this. We also have a shortage of healthcare professionals globally, 18 million. We're not going to magically produce more doctors, but if we use a doctor's time, a nurse's time more efficiently, and I think technology can be an important channel to do so, we can improve access to healthcare professionals significantly. So really looking at reducing waste and improving cost, using our workforce better, improving quality and safety, and then fundamentally improving access to care. People should be able to access a healthcare professional when they need it. And I think what the digital economy that we have now, the current industrial revolution, and as we look at transforming healthcare from a patient perspective, what patients are looking for to be connected, to be able to access the care when they need it. They want to be cared for. And the examples are replete where patients simply feel like they're a number. They want their doctors to know them. And even in a digital advanced digital economies where healthcare has electronic medical records, oftentimes the doctors don't know their patient because there's so much data in there that it's impossible. So how do you actually create that proposition where you really have that human touch? And ultimately, in an era of data proliferation, you want the doctor to know to know you at a level that's much beyond the 10-minute or 5-minute or 15-minute encounter. The social determinants of health, the data that resides in other institutions, that should be integrated and provided so that when a decision is being made for a care of a patient is based on the best slice of data, the best insights that are gleaned from that data. So what we are seeing is that, we have a lot of new technology around us, and that has to be woven together into new models of care. And this is really part of the conversation we want to have, right? It's really how do we not only optimize hospital, but how do we actually create a new system of care so that, care that belongs at home is delivered at home. Care that belongs in a hospital comes to the hospital. And the reality is hospitals are an expensive place to get care. They are risky places to get care. And when you look at history, hospitals were meant to be for patients who needed really, really complex care. And the phrase is hospitals are a place where patients went to die 100 years ago because they were so sick, right? And when we look at modern day, it's really about critical care. It's about surgical care, things that cannot be delivered elsewhere. And when you look at, pure business perspective, if we are optimizing hospital space for patients who are complex, it's actually better business value proposition for that investment that's made. So really thinking about not only the hospital space, but extending hospital services beyond the four walls. And that is really, I think, kind of where we want to begin to challenge this group is how do we create a workforce? How do we create paradigms where we can begin to imagine a new paradigm of care? So the last 20 years have been pretty phenomenal. I remember the time where when mobile phones were not in India, it was difficult to connect. Land-based infrastructure was relatively inefficient. And then when mobile infrastructure came, it transformed lives overnight. And this is an old story now because, the average penetration of a phone is almost 1-to-1 in India. And as more and more people have gotten access to a mobile phone, we've seen a proliferation of data because as people use their device and services, we are accumulating a lot of data about human behavior, about social determinant, but their ability to connect to not only their family and friends, but also to businesses and health services. But all the data that's generated creates another important area where we need to begin to invest in, which is data and analytics. But the irony of this is that more people have access to a mobile phone than they do to clean water, electricity, and a toothbrush. And that's really where we believe is the opportunity. Elliot, you may want to add a couple of lines, a couple of comments here.
Sure. So, I've worked with integrating the healthcare enterprise now for about 22 years, and it originally started in radiology where we had CAT scanners, and CAT scanners are the first devices that were computer and data based. But as you work your way around that wheel to the right, so many different kinds of devices now are digital. and create digital data. And we have an ecosystem of technologies now that create data. And in fact, they have their own data emporiums in the radiology or laboratory or other areas. And so these are rich opportunities for us to gather data about patients, and it requires integration of work processes and workflow. A surgeon needs to have the pathologist's information in order to conclude a surgery, for example. And the patient needs to have access to pharmacy information and the physician in order to make good prescribing decisions. So we have an area that is data rich, and we have an opportunity to connect systems in a way that automate the communication and sharing. Again, it's more about allowing the physician to know about the patient in near real time. And ultimately, it's all about quality, and it's also all about helping physicians and nurses do more with their time.
And this leads to, the unintended consequence of creating very efficient data acquisition systems within the healthcare enterprise. We have done a tremendous job in many countries, including the US, of gathering data through electronic medical record, but we have actually drowned the insights and the information that physicians and nurses need to make better decisions. And I would say everybody in a healthcare enterprise. And this is one of the things we want to avoid as we begin to create investment opportunities in healthcare and in India. The compounded annual growth rate of data in healthcare is 36%, the highest of any industry. By simply collecting all this data and giving to a doctor in a 5 or a 10-minute encounter, we're not going to solve the challenges we are trying to solve for. We really will need to begin to think about a data and analytic strategy that delivers insights so that folks can make better decisions, whether you're a C-suite executive or whether you are a frontline nurse. We are all starving for insights and wisdom, and that's what these systems need to deliver to us as we begin to look at digital transformation in India.
And just
the other thing,
quickly, to point out, I've worked with the U.S. federal programs, international programs in digital health for 20 years. And what I've said is that the doctor in the emergency room doesn't want the Wikipedia of Elliot Sloane. They need to know about the current illnesses, medications, and challenges that I'm facing, not that I had scarlet fever when I was 5 years old. So, we have to really be very careful and thoughtful about how we make information available and usable for physicians, nurses, and patients.
And also, I think the level of the technology, which if you take the example of the CT scan, which was digitizing the organ images through the computer-based systems. And then because there were images and somebody has to interpret it. And then through machine learning, a system came when the machine is giving you the outcome. And now, more than that, now the whole field of the artificial intelligence and algorithms has taken this to a very different level. So where altogether, let's say the movement of my body while sleeping, converting it into respiratory rate and pulse rate and non-invasive blood pressure and giving me alarm. So that way, that has taken it to altogether, the scope of this digital application is becoming really huge. And we need to learn about it.
Yeah. And Dr. Agarwal and Elliot, this reminds me of a book that was written by Dr. Robert Wachter out of California, The Digital Doctor. And one of the things that he writes in that is his experience walking into an ICU. And we can all relate to that. When you walk into an ICU, we hear beeps. So he asked one of the nurses, how do you know which is a critical beep? And the answer was stunning. She said, when there is no beep, because the patient has flatlined. And when we think about what we have created as a paradigm is a noisy place that does not call attention to what's critical. And this is where, when we think about, everybody talks about AI and AI as the hype, But when we think about if AI can help us consolidate those data points and call the nurses or the doctor's attention to the patient who really needs the attention at that moment, that is really what we're talking about. So it's really bringing all these technologies together to saying that in the ICU, we need to create a paradigm where our staff is paying attention to things that are really going to lead into trouble, or create predictive algorithms that are going to predict sepsis 3 days before it occurs, right? And I think that is the mindset if we take and say, let's define the problem, let's define the data that's needed to measure the problem, and then work backwards. What are the people that's needed, training, what are the processes that need to be re-engineered, and this is really important. You simply cannot layer on top of an old technology on top of an old process and expect a better outcome. You only increase the rate of at which errors are made. So optimizing processes and then saying what technologies do we need to support that. And oftentimes, technology is never the barrier. If the other pieces are aligned, technology implementation actually becomes very easy. So when we think about the fabric of healthcare, it's really around, and I'm just gonna. It begins with leadership, and as we look at CAHO and as we look at the team here, this is really what's needed. Leaders who are committed to creating change, creating the right culture. Because if the culture is not right, no matter what strategy one has, it will fail. And so strategy and governance become really important. And then you invest in people, in education, skills, and training, the processes, which should be standardized and outcomes driven, and then data-driven insights, which are fueled by information technology. But the critical link in all of this is change management. And this is one of the things that gets overlooked oftentimes. Change is hard, especially in healthcare, where there is a bit of conservatism, and rightfully so, where people need to be led through the change with delicate hands. So investing in the right resources to lead an organization through change becomes really important. So fundamentally, it's really looking at creating internal resilience, which is investing in building a workforce, which is what really we want to focus on, right? How do we begin to prepare the next generation, or even the current generation of the workforce to support a digital enterprise? And how do we begin to create programs and build technology portfolios around them? So when we look at some of the examples we'll share with you, and I've just, so in the US, and we'll give you some examples of, what we've seen there. So for instance, the American Board of Preventive Medicine actually has qualified clinical informatics as a subspecialty. I'm actually board certified in that. And they really focus on, cultivating a genre of physicians who can be leaders in the technology and digital health. And the curriculum involves 5 main domains. It's fundamental knowledge and skills. How do we improve care delivery and outcomes using digital technologies? What do we need to have in terms of skills around enterprise information systems and data governance and analytics, and then leadership and professionalism. And I just put that there just to highlight that the competencies extend just beyond EMRs and technology. It has to do with statistics and network architectures and database and standards and privacy issues and predictive models, risk stratification. So as you can see, a broad-based competency that can really create champions at the physician level who can drive the change that is aligned with the desired outcomes. So, and I've got the links embedded there. So, certainly feel free to go and explore those websites. Similarly in nursing, nursing informatics is now a subspecialty as well. Nurses can get a certificate. And nurses are your key change agents. Having well-qualified, well-versed nurses who are empowered to drive the change can actually create significant impact. And again, you look at not only competencies around technology, but things around, project management and data management and quality and safety. And it's one of the specialty certification along with family nurse practitioner and gerontology and med-surg and others. So similarly, the American Association of Hospital Pharmacists has a informatics curriculum for them to train pharmacists to become much more engaged in maintaining and implementing technology. And again, it has to do with, as Dr. Agarwal pointed out, how does technology apply to the pharmacy workflows? Robotics and automation are big in pharmacies. Drug safety, medication safety is extremely important. And having pharmacists drive that in a manner that is skills-based becomes really important.
And supply chain as well is a huge player in that.
That is exact. Thank you, Elliot. You're absolutely right. Same thing with lab and pathology. And last year, we actually partnered with CAHO to actually put a few articles together to stimulate thought leadership around how do we think about digital transformation from HIMSS maturity models to certification programs to emerging technologies like artificial health to personalized digital health and so forth. So, the issue is available to all of you, and certainly this was just a starting point to begin to think through the complexity and the nuance around digital transformation. The reality is digital transformation is hard, and it is prescriptive. There is data out there which says that if the right drivers are there in a macro environment, the digital transformation happens quite rapidly. One of the things that we've heard in India is a lot of executives have said, well, there is no driver for us to change, external driver. There are health systems that are saying quality is important to us, safety is important, we will proactively invest. And what we see is that in a market like India with 1.5 billion people, the largest population on the planet now, and enough of a consumer base that can afford and knows about quality, I think that becomes a key driver. So health systems that are going to attract the premium customers, patients, will have to deliver global benchmarks because this population has access to everything. So we really believe this is an exciting time because the drivers are firmly entrenching themselves. And as lessons from US and other places show, the moment you reach a tipping point, things move pretty fast. And then health systems are largely in a reactive position. And if we can create a paradigm where health system leaders are in a proactive position, it actually creates a much, much stronger, not only clinical, but business proposition. Elliot, you want to add a few comments on this slide?
Yes, just to emphasize that this is a journey. I started working with the federal programs in the U.S. in 2005, and we are still growing and changing and evolving. The more we know, the more we learn, the more we want to improve the system, and the more we want to provide resources for physicians and nurses to allow them to do more quickly, and also to engage the patients and their caregivers. So it's a journey, and it has to be tailored to India's needs. What we did in the U.S. met the U.S. model. What India needs to do is going to be largely a process that has to engage you leaders in deciding where are the priorities, where are the highest returns on investment. Back to you.
Yeah, thank you. And I will add one more thing is if we look at sequencing, investment in technology, there are data points in literature that show that certain things are going to yield are critical as foundational components, but then as you reach maturity, you can actually improve the yield on the investment.
Well, let me also point out that technology has accelerated so quickly. When we started in 2004 and 2005 in the US, apps didn't even exist. The iPhones and iPads and analytic tools didn't exist. If we were to start today, we would take a different path than what we took then. Even cloud computing didn't exist. So India is stepping into this and can leapfrog, I think, a lot of the inertia that we have been struggling with in the US.
Yeah. And the other thing I think, CAHO's engagement at the policy level becomes important also. because there are clear opportunities. If the policies are done correctly, they can make a huge impact in terms of outcomes, but also at the pace at which you can accelerate and the cost that's needed to achieve that. There are a number of shining star stories in India, and this is one, a case study that we're aware of that Pull Alliance has kind of worked with, is an example out of Chennai where one of the largest insurance companies in India, as a CSR, invested in some smart technologies for a primary health center or 3 primary health centers. And it started out as a COVID clinic, but then they expanded to chronic disease management and they offered assisted telemedicine. And the investment of a relatively small amount of money in people, you see the doctor and the nurse there, but some smart technology like the stethoscope and the electronic medical record and assisted telemedicine and point of care diagnostics, they're able to see 20,000 patients over 2 years, 15,000 general consultations that led to 5,000 assisted telemedicine visits. So within a 30-minute span, a woman or a man from a low-income setting could actually come in and walk out with a bag of medicine, including seeing a specialist. That is unheard of even in the private sector in many parts of the world. And this is what transformation looks like. It's really not about expensive technology; it's about technology done right. So really, defining the problem, saying that what is the best suite of technologies we need, and what are the people that's needed is the way to go. Dr. Vijay, did you have a comment?
So, no, Manish, I think examples like this are again very motivating. But the issue is, again, we have to look at it from the people who have not started. And for example, and that's where at one stage, your HIMSS maturity models that we talked about, the issue is this, that could there be some guidance for the people who have not started? How should they build up their digital health ecosystem? Let's put it. If you can just take up some, because you have a good idea of hospitals in India. You see, the thing is that people who are smart, they are moving ahead with technology, and the examples like this will come up. The problem is there are huge number of people who do not have probably the motivation, or you can say the inner drive, or they feel that, all right. And all said and done, somewhere human touch, people say, is being lost when we are adopting these digital technologies. And that's what also needs to be integrated. You even referred earlier that as a doctor, I need to know the reasonable and the right kind of data so that I spend time with the patient to then do what only I can do. Right. That machine cannot do. So I will say that that's also a question already in the question box as to this from Pratibha Pereira. She's one of our very senior members of CAHO, that how does one work to assess digital preparedness if the core person, that is the patient or carer, especially in a country like India, where we have rural, semi-urban and urban communities. So.
And thank you for that question, first of all. And I think it's safe to say is that starting on the journey is more important than reaching a certain maturity. And the way we like to think about that is begin with the problem definition first. There are high impact areas, whether it's on revenue cycle, whether it's on supply chain, whether it's on clinical processes, clinical outcomes. That I think if a health system says that here are these 3 areas that are the cost of my biggest opportunity that I want to improve, and begin to think about how do we begin to string together the digital transformation in that workflow. That's the simplest way when you look at it horizontally, is where you begin to see outcomes. So rather than saying, I'm going to digitize the whole hospital, perhaps thinking about, I'll give you an example. We want to improve medication safety in the hospital, right? I mean, Safety is something that CAHO stands for. We want to improve medication safety. So perhaps thinking about pharmacy automation and e-prescribing within the hospital enterprise, where you have, automation across that whole workflow. Labs are another area where automation there can actually support safety. So begin to think about safety and quality are our goals. Which are the processes where most patients are being harmed? And defining that. Thinking about where the hospital stand to gain most revenue or lose it more revenue. So that becomes an important area where you can actually begin to think through revenue recovery to feed some of the investment that's needed to make this transformation happen. So I think rather than starting that this is an app that's there to get something done, thinking about, this is the problem we want to solve. You may at the hospital say that, we want to reach a larger market area, and telemedicine is a way to do so. So building a program around that. So bringing in a telehealth solution is not going to do it, because if you don't have enough doctors or a chronic disease management program, you're really not going to be able to do much in terms of showing outcomes. So I think defining the problem statement and working backwards may be a way to begin to show impact, and then building upon that, because this itself is going to break the culture and change the culture, where people will be able to see, hey, this is something that's really going to improve our bottom line. Elliot, you may want to add any comment to that as well.
There's no one size fits all. Again, the U.S. experience, we created regional centers to provide that information technology support, because throughout the U.S. we have some very Spartan states with small populations and very small hospitals. So this may be something CAHO can work on with the government to facilitate those resources as a bootstrapping effort, and also we engage the professional societies, the surgeons, the radiologists, the pediatricians, to start building the standards of care, so that we could begin to create governance. You can't impose this from the top down. This is something that requires a team effort nationally to succeed. And again, when we started, apps and low-cost information technologies didn't exist. Today, they exist in abundance. So now it requires, I think, more focus on which resources will create benefits for a win-win-win: government, hospital, physician, and ultimately patient, so that we have better systems more rapidly developed.
Yeah. So do you feel that, for example, at least to bring about or bringing most people in the hospital on this kind of a thought process, absolutely right, that each function and each department can look at as to where is the problem and what are we solving, but to maybe start thinking of adopting a very cost-effective hospital management system, or that could be like start becoming, and especially in view of our Ayushman Bharat digital mission, we have today at least a backbone which is now coming out with certain standards, which is helping you to be even producing interoperable healthcare records. So that's one of the things that, patient is getting treated in one hospital, the record can go on to the next hospital. So I think that we should look at the kind of solutions that are being offered through that ecosystem, where they are also looking at very low-cost hospital management system solutions. And maybe I'm saying that could be at least one beginning. And other than that, you're absolutely right that looking at each segment and having a discussion with them, or the administrators can feel as to what is their maximum pain point, and we can try to create the digital solution around it.
And to add to that, Dr. Agarwal, I think there's also an opportunity to think about new models of care delivery. So, when you think about a hospital without beds, creating centralized capacity that feeds other hospitals. So, we are aware of, some companies coming out of India that are providing remote ICU services. So when you think about transforming, let's say, critical care. Perhaps the model is subscribing to a service or creating your own service that feeds smaller hospitals. So thinking through, creating scale with the technology investment. And that may be a faster track to cover a larger population. And in the US, you also have a similar example where you have a hospital like Mercy Healthcare, which is a hospital without beds. And all they have is centralized capacity, and they serve tier 2 and tier 3 hospitals in providing access to critical services. So I would say that those kind of business models are quite effective, and they actually rapidly scale a very specialized skill set clinically, but also from technology to a much broader set of audience. Elliot mentioned earlier, infrastructure is becoming less of a cost burden because rather than being a capex, it becomes an opex. If you begin to look at cloud-based system, which India is moving forward. So certainly, I think looking at not being wedded to the traditional hospital mindset, but really thinking about is there a different way where we can create a business line or we can actually benefit from somebody who's providing a service.
So I think one of the questions, again, by one of the very senior persons, Dr. Anil Chatterjee, talked about generative and degenerative AI. So generative AI, I think already I alluded to that with the use of algorithms, how a lot of decisions, predictive analysis can come from it. But he's also alluding to something, is there a degenerative AI and what could be its impact on healthcare?
Well, I'll speak to that briefly. We have many different layers of AI. In applied AI, we can have technology and practice specialized AI. So we have a lot of development of algorithms in radiology to assist physicians in diagnosis and pathology, and a growing number in general patient care, and a number of smart devices that are handling things like emerging sepsis or cardiac conditions. Generative AI and large language models can be helpful for the population and for caregivers and public health, looking at what is known around the world about, let's say, diabetes or chronic heart conditions. Degenerative AI is a relatively new term. It's trying to use AI tools to correct the errors in other AI tools. We have what's called hallucinations in AI, where AI can improperly infer that drinking soda, sugared soda, will help a diabetic manage their diabetes. And so these are also called multi-agent systems that do negotiation between different AI models to try to find ground truth. And we also know in healthcare and in medicine and science, what was true 5 years ago is not the truth we know today. Medicine changes at a very rapid rate. So they all have a role. An individual hospital is not going to develop their own AI. They will develop perhaps AI for their own decision-making at the local level to improve productivity or safety or quality, but they're not going to be generating these large AI. They're not going to write their own algorithms for tumor detection unless they're a teaching and research hospital. And by the way, India has contributed tremendously to a number of these advancements. So hopefully that answers those questions.
Yeah. So is there an issue of ethics involved in using digital health? That's another question, actually. Well,
That's a broad question.
It's a broad. There's ethics in all kind of healthcare. I mean, yes, a defective system is as bad or more dangerous as a defective physician or a defective hospital. So in digital health, we don't want to lose the touch. We don't want to, the patient needs and is entitled to a feeling that they are being cared for. And there are ethical questions related to privacy and confidentiality. So there are very complex issues. What one patient wants as their outcome may be different than the rest of the population. They may not want to be treated. They may want to be allowed to die with dignity and comfort, whereas best practices would insist that they receive a certain procedure. Briefly, my father went through that in his late 80s, and I was constantly helping him re-guide his patient journey, and he was a physician, to his beliefs and preferences, not to the standards of care. So there are a lot of ethical issues, but they're part of what we all deal with, I think, in medicine, and that's why we're together working on this.
Yeah, so I feel that I don't think this question being so generic can be answered in yes or no. It's only on a very, very case-specific basis one can say whether what you did was ethical or not. And in most cases, I think one with just a common sense will be able to answer that. If you have acted in the best interest of the patient and within the governing ecosystem, I think you are quite well within the ethical rights. In fact, not to use digital health may be unethical in certain cases. So if you are not using digital health and you are making a patient wait for 45 minutes, I think is unethical.
Yeah, I will also, add to that. There's a book called "The Future is Faster Than You Think," and one of the impressionable lines in that is technology leading mankind, or is mankind leading technology? And I would say same with healthcare, right? Healthcare has to be clinically driven. What is in the best interest of the patient? And we really need to be thinking about embracing digital technology in that sense. And Dr. Agarwal is right. By not embracing the right technology for the right use cases, we may be doing patients disservice, right? So it's really thinking about ethics as a broader rubric within healthcare. How do we begin to protect the needs and the interests of the patient, and what becomes the right modality to do so? If we are not achieving the right outcomes, if we are harming more patients, to me, that's the biggest ethics violation that we can commit as a healthcare fraternity.
And CAHO could play a very important role in articulating, some fundamentals of this. And one of the ethical, boundaries is we don't want to send patients off literally on an iceberg or virtually on an iceberg to care for themselves. There's a balance, and we are constantly striving to find that right balance.
Just one more thought on that. Ethics is a big topic, and one of the things that I often say that forums like these need to have more conversations around ethics. The reality is we should be thinking about ethical use of whatever technology that's coming in. So for a health system to have patient data and to sell it to drug companies or to use it for other purposes, that is unethical. And to have the right, like Dr. Agarwal mentioned, and Elliot also alluded to, having the right governance in place to make sure that we are protecting the patient's interests in the best manner possible. It is part of what digital transformation is about. So to do digital transformation by saying it's just technology misses the boat. Really thinking through all these issues becomes super, super critical.
And AI plays a role in this question of ethics, because if you're using a database that's 4 years old, that's not current medical decision making. So there's, again, this is a rich discussion that we should have perhaps in a following seminar, in a following meeting, and working on priorities for what topics should be addressed in the year ahead, for example.
Yeah, so I think one of the things that is coming out right from the early part is, number one, I think some of these discussions should be happening in segment wise. For example, if you are wanting this to discussion on supply chain, so there, of course, the administrators and the supply chain people could be, could be sitting together, or we can be sitting with them to show them the best case studies which are happening all over the world or whatever, what have been their challenges, advantages, what is the present system, what is the pain point. Because just to embrace again technology to make it more, make the healthcare more expensive will not work in our country. So one of the things is to probably, because what happens when we do this conversation in a general way, like we did today, where there are people from different background, I don't think that there is a specific deep down drive we are not making into what is it that I'm trying to talk to the supply chain, what is it that I'm trying to talk to the nurses. And I think we need to have conversation with them to understand their viewpoint, their pain points in adopting the new systems, and at least showing them the best case studies. Even I think making a library of the best case studies under different departments, under different functions, can be again a very good work that we can do through Pull Alliance. All, I would say, like the example that you showed of the smart clinic in India. So if we can go as to how other people can, if they want to replicate it, I want to know all about what has gone about in building it so the other people can replicate. Unless I know the road to the scaling it up or following, I'm able to do the same thing, it doesn't help me. So back to you, Manish. Yeah.
Yeah, I saw a couple more questions around the documentation burden on physicians in NHS and in the US. I'll give you a very concrete example. So I also have served as a assessor for the EMR adoption model for HIMSS. And, folks might be aware of the EPIC system that is the largest health information system in the US. Well, they also have implemented in Australia and other countries. So in the US also, the burden of documentation could be as high as 40 to 50%. And the user experience, not just EPIC, but EMR systems can be suboptimal. So when I was talking to the clinical team, doctors and nurses in Australia, and they were using EPIC system as well, and they absolutely loved everything about the system. And the reason was not around technology, because technology is designed to work in each regulatory environment. It was actually the regulatory environment that was impacting the experience, because in the US, the requirement to document is very high. So doctors have to create these copious notes, and largely for billing purposes. Whereas in Australia, the EMRs are used for complex care coordination purposes. And so for them, it was actually a tool that enhances patient care first and foremost. And I think that's sort of the critical difference. And this is really where I think the interface between CAHO and the regulators becomes really important, right? As India is rolling out the National Digital Health Blueprint, as policies are being codified, being able to make sure that it's done for the right objective, so that we are delivering the right experience. So absolutely, India cannot afford to have 40-50% of physician time going towards documentation. So creating a regulatory paradigm that supports that, a financial incentive network, a mechanism that incentivizes doctors and nurses and health systems for delivering the right products and services and outcomes, create the macro drivers that lead to the outcomes. And the question was also, how do we create an adoption model for doctors and nurses? It's actually not truly an adoption model. The adoption model is there in terms of implementing a system at the enterprise level, but creating the right drivers. If we incentivize and design the systems in a manner that supports better clinical care, I think that leads to greater adoption, in my experience, than anything else. If doctors and nurses feel like the technology is helping them, their adoption is going to be higher. And I can give you a couple of examples from when I was at Johns Hopkins, where even a portion of the physician's quality compensation was tied to appropriate use of technology. A very small component, but it led to a tremendous adoption of technology. Now, it didn't mean that you could throw an imperfect tool and say that adoption will be high. You had to work synergistically. Create the drivers for physician and nurses to use the technology, but give them the tools that are functional. No, you cannot give them something that is dysfunctional and expect a superior outcome. So it's really, having the two in place creates much more assurance of transformation, successful transformation.
Thank you, sir. Thank you so much. Thank you to all of you for giving us a lot of insights and a lot of dimensions which are yet to be discussed, explored, and implemented. I liked all the slides, which you have presented. A very good thought and clarity we got in the scheme of things, especially those critical factors in one pie. It is hardly anything, and in the next, how it should be. It's a big pie. Especially the integration of various softwares in the hospitals. Non-integration is the biggest challenge because every vendor asks the money to integrate with the another, and then communication between all these applications will remove the redundancy, duplication of data, and will ease the life of all the users in the hospital. So I'm very happy, elated to attend such a intellectual presentation and great thoughts which we can consider while we are evaluating any hospital information system, or while we are implementing any solutions or thinking about it to adopt any solutions, especially the big pie of health apps and robotics and the AI models and applications that we think that all these are required, but actually we need to evaluate that what our system and hospitals actually need, and basis the need of the patient, the scope of services, and the users, which suite we should have. We need not to have all the suites on the table. So it's a great learning. I invite Patil sir or my other colleagues from the GC to ask any questions or comment.
Thank you, Dr. Nishant.
Yes, sir.
And the presentation has been very insightful. And of course, the learning, which Dr. Manish has said is to create a workforce from the down, the caregivers to the upwards. So that is, I think, the model which hospitals should try, and that smart clinics and hospital without beds and the remote ICU monitoring. I have liked these thoughts. So let us see in great insightful has been provided, and how we can adopt these things in the future. We have to go. Thank you.
So
Wonderful
at the
presentation.
DC level, Dr. Patil and Nishant
Yes.
and others, what I would want is let's start to make now individual segment champions. Let's try to now see who can drive or talk about the technology for the supply chain, who can talk about in the diagnostics, we can talk to the lab people. And similarly, I'm saying let's break down the various functionalities in our healthcare delivery system so that we can have at least some discussion to understand where we are in India, where is the rest of the world in that particular segment, what is the learning from the mistakes that others have done so that we don't repeat it, and how do we make the best use of the technology in each of those segments. Because I feel that talking in a generic way, only what happens that it is the administrator who keeps on thinking of some particular thing and says, all right, why don't we do this or that? But I think we need to make the champions. Yeah, Manish, what is your thought about it?
I had a related thought. One of the trend that we are noticing that every hospital is investing in building their own EMR systems in India. And I think part of this is because folks feel there's no viable commercial solution, but also labor costs are relatively cheap to build something of their own, and they want something custom. Lessons learned from elsewhere, most health systems that have developed EMRs of their own realize they're not IT shops, and they have actually gone the way of commercial. I think this is a huge opportunity in the market where you need some viable supplier that provide products that are going to serve the needs of the mass hospitals. I think that's going to lower the cost and access. And I think this is another area where perhaps engaging the vendor community and saying that, as a community of accredited hospitals, here are the needs we have. And if you have 5-10 viable vendors, then you have a rich pool to choose from rather than trying to become IT shops yourself. So I think this is something that at a strategic level is very important to get our arms around.
Yeah, good idea. Yeah.
And very few countries have created monolithic, unified medical record systems. Most countries have found that a form of federation that allows sharing of data between different hospitals is more realistic, just the way banks and airlines share information. We have a lot of examples in the working world and supply chain that allow us to share information. So I think there are some very good models to follow that India wants to look at. And I think CAHO can help be a leader in having those discussions and coming to consensus on some strategies.
Yeah, Dr. Saurav Mati. Yeah, you're muted, Saurav.
Oh, thank you, sir. It was a very insightful session, and while hearing, I was realizing that probably we are yet to recognize our strengths and weaknesses. And I was wondering if a national survey in this regard will be beneficial or not. That was my thought, sir.
Again, I'm saying you can call that as a survey, but what I'm saying is that let us start to create segments within the hospital, because otherwise a general survey will talk about something, it doesn't help anybody. So I think we need to do a survey, for example, that what is the extent of technology being used in the physical medicine and rehab? What is the amount of technology being used in various clinical departments? Or what is the technology being used in supply chain, admission, discharge? So I think we can think of the 25 of those buckets, and we can do a kind of a survey or exchange of thoughts as to, and we can try to know who is a leader in that particular position in our country and some things of that kind. I think that may be one area to work on. And that's something what you are saying, Saurav, maybe. Yeah, Aninda Chatterjee. Aninda, you can unmute yourself.
Yeah. Can you hear me?
Yes, we can hear you.
Yeah. I take the privilege of getting an answer for one of my questions, since all this, Sir Elliot is here and Dr. Manish is here. See, this question is a combination of ethics as well as technology. Regarding the BRCA1 and BRCA2 genes, it tells you about the future prospect of having a breast cancer. So many of the employers who actually fund you for your healthcare, etc., they screen you for BRCA1, BRCA2 genes at the time of pre-employment, or insurance companies also do that. So now my question is, with generative AI, without supplying the data or the test of BRCA1, BRCA2 genes, does generative AI in USA have the capability of assessing the BRCA1, BRCA2 genes status by actually assessing other data and other healthcare reports submitted?
Aninda, what I'll say is that
it has to be a subset.
Yeah. This is altogether
yeah, I know, but
discussion, but we'll definitely.
They're from the US, so I thought
I'll help you connecting with them so that you can.
Yeah. Thank you so much. Thank you so much.
But
okay.
I think so. I think Father Johnson has left. So I think let's bring. Elliot. You want to say something?
I was just going to briefly say that setting priorities, where is the most meaningful impact, is important. We in the U.S. we found that medication errors, and a lot of the around the world, a lot of the waste was related to medication errors, and that's not pointing a finger at physicians. That includes the supply chain. It includes the patient not taking medications or taking the wrong medications. It includes physicians who aren't aware of other physicians' prescriptions. But we found in the US and many other countries that that is a major source of waste. And if that is true in India, then that would be a priority area that I would recommend.
Yeah, probably we will do I think now we can do a series of this talk on different segments and where you can bring in the global expertise and we can try to bring the local people of that particular area and to see anybody who may be in the best position to present his case study.
Correct, sir.
So I think with that, I think thank you very much, Dr. Manish and Elliot, for devoting your time and energy. And maybe we look forward to let's do something with the Pool Alliance and let's make it work around CAHOCon. It will be a great idea to do that work there.
Thank you for inviting us, and thank you for the active participation of everybody and for your leadership, Dr. Agarwal.
Thank you.
Yes,
Over
thank
to
you.
you. Yeah. Over to you, Nishant.
Thank you. So, thank you so much, sir. I thank all the 150 participants for giving us time on this festive weekend. And a Happy New Year to all of you. Have a healthy New Year in the coming times. And we will be conducting our 21st CXO Roundtable on 19th of January. And as we have discussed, we will theme it very specific to a particular segment by segment for the entire hospital, all the users as sir has guided. And we'll get back to you with the more structured, focused themes on digital health interventions. Thank you to all of you.
Thank you.
Yes, sir. Bye-bye, sir. Thanks.
Bye all. Thank you.
Bye.